All right, welcome everyone. Today we are jumping into a really classic and crucial comparison, something that comes up all the time in clinical practice and is an absolute must-know for any specialty exam. We're going to be differentiating G6PD deficiency from hereditary spherocytosis. This is designed to be a super high-yield explainer, making these key distinctions really stick.
And before we dive in, I want to give a huge thanks to Dr. Mohammed Al-Nagi Mohammed. All of the fantastic comparative data that we're going to be looking at today comes directly from source material he expertly compiled. We are really grateful for such a clear and concise framework for our session. Okay, let's get right into it with a core clinical puzzle. Picture this. You're called to see a male neonate. He's of African descent, and he presents with jaundice. You're thinking it's a non-immune hemolytic anemia. So what are your top two differentials? This is the exact scenario we're going to unpack today.
So here's how we're going to break it down. We'll start with that clinical puzzle, then we'll walk through genetics, compare the clinical histories, look at the all-important blood film, and cover the definitive diagnostic tests. Then we'll wrap it all up with a high-yield summary of the key features that set them apart. It's a clear path to getting this down cold. Okay, so let's get back to our case. Telling these two conditions apart isn't just some academic exercise for an exam. This is a fundamental skill. It directly impacts your workup, your management plan, and, really importantly, how you counsel the family. Now, for our first set of major clues. And what's cool is that before you've even ordered a single test, the patient's profile, I'm talking about their gender and their ethnic background, gives you a massive head start in narrowing down your differential diagnoses. And check this out, this table splits our two possibilities so perfectly. For G6PD deficiency, notice it's X-linked recessive. What does that mean? It means it's overwhelmingly going to affect males, and ethnically, you're looking for individuals of African and Mediterranean descent. Now contrast that with hereditary spherocytosis. It's autosomal dominant, so it hits males and females pretty much equally, and it's classically associated with folks of Northern European ancestry. So in our clinical case, the patient's profile is already pointing us very strongly in one direction. Okay, so we've got the patient's profile. Now let's build on that with a clinical history. The way the symptoms actually show up, whether they're sudden and triggered or kind of chronic and always there, is another huge piece of the puzzle. And this just lays out the two different stories beautifully. Yet both can show up with neonatal jaundice, but G6PD deficiency is all about these acute hemolytic episodes that are kicked off by oxidative stress. Think about infections or certain drugs like sulfa drugs or even fava beans. Hereditary spherocytosis, on the other hand, usually presents a much more chronic picture of hemolysis. And here is a huge physical finding. Splenomegaly is common in hereditary spherocytosis because the spleen is working overtime to clear out all those abnormal red cells. But it's not a typical feature of G6PD deficiency at all. All right, time to get visual. Let's move to one of the most powerful tools we have in hematology, the peripheral blood film. This is often where your clinical suspicion gets its first tangible, visual confirmation. And the evidence you see under the microscope is just strikingly different. On the left for G6PD deficiency, the hallmark is Heinz bodies. These are these little dark clumps of denatured hemoglobin, and they're a direct result of oxidative damage that the deficient G6PD enzyme just can't handle. You'll also see bite cells, where splenic macrophages have literally taken a bite out of those Heinz bodies. Now look to the right for hereditary spherocytosis. The cells themselves are the clue. See those spherocytes? They're small, dark red cells, and they're missing that normal central pale area. That's because they've lost membrane surface area from that underlying protein defect. I mean, it's two totally different pathologies and two very distinct visual signatures. So your history, your exam, your blood film, everything is pointing in one direction. You're feeling pretty confident, right? But to make it official, to really put a stamp on it, you've got to turn to specific, definitive lab tests. Let's look at the gold standards for each one. And you know what? This part is refreshingly straightforward. To confirm G6PD deficiency, you do exactly what you think. You measure the G6PD enzyme activity levels. For hereditary spherocytosis, the standard is the EMA binding test. That's a flow cytometry test that actually quantifies those membrane protein defects. So again, two different problems, two highly specific confirmatory tests. Okay, we've walked through the whole diagnostic journey. Now let's pull it all together into one final, super high-yield summary. Seriously, if you're studying for boards or just want a quick refresher on the ward, this is the slide to screenshot. Let's lock this in, okay? First, inheritance. X-linked G6PD versus autosomal dominant HS.
Next, the clinical picture. Think acute, triggered hemolysis in G6PD versus that chronic hemolysis in HS. On physical exam, splenomegaly is a big clue for HS, but not G6PD. The blood film, it's Heinz bodies versus spherocytes. And finally, the confirmatory test, an enzyme assay for G6PD versus the EMA binding test for HS. These 5 points, that's your core framework for telling them apart, every single time.
So we've got the tools. We can tell them apart. But that leads to a bigger clinical question, a final thought for you to take away. Now that you can differentiate them, which condition do you think presents the greater long-term management challenge for the patient? Is it the lifelong need to avoid triggers in G6PD deficiency, or is it managing chronic anemia, gallstones, and a potential splenectomy in hereditary spherocytosis? It's something to think about as you apply all this knowledge to real patient care. Thanks for joining me for this explainer.